Hello everyone, welcome back. And today we are going to start with another topic, that is your Warthin's tumor. And Warthin's tumor has been asked as a 5 marker. Okay, so let us start with Warthin's tumor. So adenolymphoma, which I am unable to copy, but adenolymphoma is another name of Warthin's tumor, right? So adenolymphoma is another name of Warthin's tumor. So what is Warthin's tumor? Warthin's tumor is the second most common tumor of the salivary glands. Okay, and it mainly occurs in the parotid. So Warthin's tumor is the second most common tumor of the salivary gland, and it occurs exclusively in parotid. So tumor of parotid is Warthin's tumor, can also be said. It is also sometimes seen in the submaxillary glands and intraoral glands. Coming to the histogenesis, the tumor arises from the salivary gland tissue entrapped within the paraparotid or the intraparaparotid lymph nodes. Now, what does this mean? So, what does the histogenesis say? The tumor arises from a salivary gland tissue entrapment. So, when there is embryogenesis, and there is a development of the paraparotid or the intraparotid lymph nodes during embryogenesis, these lymph nodes get entrapped in the salivary gland tissue. Okay, so the tumor arises from a salivary gland tissue entrapment within the paraparotid or intraparotid lymph node. So basically the salivary gland is getting entrapped within the, let's just say this is the salivary gland, this is getting entrapped in the lymph nodes. Okay, so this is your Warthin's tumor. This is just a histogenesis theory which states that the tumor arises from the salivary gland tissue entrapment within the paraparotid or the intraparotid lymph nodes during embryogenesis. Next is delayed hypersensitivity. Lymphocytes, being an immune reaction to salivary ducts which undergo oncocytic change, immunohistochemistry suggests that the lymphoid component of the tumor is an exaggerated secondary immune response. So we can say that there is another histogenic theory that says that there is a delayed hypersensitivity in the lymphocytes, being an immune reaction to salivary ducts, which is why they are giving an exaggerated immune response. Okay, now coming to the etiology, what is the cause of your Warthin's tumor? So first is the strong association between the tumor and smoking, which is documented. So there is a strong association between tumor and smoking. Okay, so Warthin's tumor might be related to smoking. Okay, might be. Okay, and having Warthin's tumor in smokers is increase in number, but no significant mechanism is known. Epstein-Barr virus may be a pathogenetic cause. Okay, so smoking could be a predisposing factor. Predisposing factors. Number 1 is smoking. Number 2 is Epstein-Barr virus. Okay, smoking and Epstein-Barr virus are the two maybe causes. Okay, now clinical features: male predilected disease seen in 60 to 70 years, average age being 62, superficial tumor lying beneath the parotid capsule and protruding through it, 3 to 4 mm in diameter, and painless, firm on palpation, usually indistinguishable from benign lesions. Macroscopic features: it is smooth, soft mass, well encapsulated, cystic clear fluid, areas of focal hemorrhage might be seen. So it is a soft mass, it is well encapsulated, soft mass, well encapsulated, cystic degeneration and clear fluid is seen. Okay, so clinical features is it is male predilected, 60 to 70 years, superficial tumor lying beneath the parotid capsule, and it is 3 to 4 mm in diameter, and it is painless, firm on palpation, usually indistinguishable from other benign tumors of parotid. Macroscopic features include it is smooth, soft mass, encapsulated, cystic degeneration is seen, clear fluid is seen, and areas of focal hemorrhage also is seen. Now histopathologically, this is the histopath. So it is again divided into two, epithelial and lymphoid component. So this is the epithelial component and this is the lymphoid components. Okay, epithelial and lymphoid components. Right, now lesion is adenoma exhibiting cyst forming with papillary projection. So epithelium is having papillary projections, papillary projections, and then there is cystic spaces. This is the cystic space, lymphocyte matrix showing germinal centers, cyst is lined by papillary proliferation. Here if you see, it is a bilayered oncocytic epithelium. Oncocytic is cancerous, bilayer oncocytic epithelium. Okay, then moving forward, the cyst is lined by papillary proliferations, bilayered oncocytic epithelium, finely granular eosinophilic cytoplasm due to presence of mitochondria. So this is granular cytoplasm because of the presence of mitochondria, right? Now that is very important, mitochondria and hyperchromatic nuclei. The nucleus is hyperchromatic and mitochondria gives a presence of granular appearance. Now the outer layer cells are oncocytic and triangular cells. Okay, oncocytic triangular cells, occasionally fusiform basaloid cells. This is the oncocytic triangular cells, and this is the basaloid cells. Okay, so fusiform basaloid cells, focal area of squamous metaplasia and mucous cells proplasia may be seen. Squamous metaplasia of these cells can be seen, then a focal metaplasia can also be seen of the mucous cells. Now frequently an eosinophilic coagulum is present in the cystic spaces, and that is appearance of a chocolate colored fluid in gross specimen. So this eosinophilic pink colored layer that is there is your cystic space, right? And in gross specimen it may look chocolatey. Okay, chocolatey in the gross specimen. Okay, then abundant lymphoid component may be present in the lymph tissue. Okay, abundant lymphoid component can be present in the lymph tissue, right? Then abundant lymph, this is your cystic space, and here abundant lymphoid component can be present. Now moving forward is the reactive cellular infiltration involving both humoral and cell mediated mechanism. So it involves both humoral and cell mediated mechanism. Coming to the treatment is papillary cyst adenoma lymphomatosum is a treatment that is basically a fancy name for your surgical excision. So papillary, because it has papillary proliferations. Papillary cyst adenoma lymphomatosum is a good treatment, and its recurrence is very rare, it has a really good prognosis, and malignant transformation is also very rare. So that's all about Warthin's tumor. It is a 5-mark answer, and you can write grossly what is there about Warthin's tumor. Now the next is Mucoepidermoid Carcinoma, that we are going to take a deeper dig into, and Adenoid Cystic Carcinoma also, in which we're going to take a deeper dig into. Before that, I just wanted to tell you one more thing, that the definition of neoplasm is usually asked. So what is a neoplasm? Neoplasm is an abnormal mass of tissue, okay? Abnormal mass of tissue, right? The growth of which exceeds and is uncoordinated with that of the normal tissue, okay? Growth of which is exceeds and is uncoordinated with that of the normal tissue, and persistent in the same excessive manner after cessation of stimuli which evoked the change. Okay, so there is a cessation of the so there is a stimuli which is applied, and then there is a abnormal growth which is exceeding and is uncoordinated of the normal tissue, which is persistent even after removal of the stimuli which evoked it, right? So that is the definition. So if I have to define it again, neoplasia is an abnormal growth of abnormal mass of tissue which is growing and is excess. Abnormal mass of tissue which is growth is excess and uncoordinated with that of the normal tissue, and it persists even after the cessation of stimuli which evoke the change, right? Now let's start with the another tumor, that is your mucoepidermoid carcinoma. So what is mucoepidermoid carcinoma? MEC, or your mucoepidermoid carcinoma, is a type of malignant epithelial tumor. Malignant as in it is cancerous, right? So malignant epithelial tumor, it is the most common type of malignant epithelial tumor, and it is composed of 4 type of cells, mainly your mucus cells because it is mucoepidermoid. Then you have your epidermoid cells because it is muco and epidermoid. Then you have your columnar basic cells and something called clear cells. Okay, these cells are distinctive to this particular carcinoma. Okay, so let's see. So 4 type of cells. First one is your mucus cells, and then your epidermoid cells, then your clear cells, and last but not the least is your columnar cells, right? Now let's read about it. So it is a prominent cystic growth which is seen, and it is observed in both major and minor salivary glands. It is seen in major and minor salivary glands. It represents 29 to 34% of all malignant tumors. Okay, malignant tumors, 29 to 34% of all malignant tumors, which is a very important data, and which says that this is a highly occurring malignant tumor. That is 34%. I wouldn't say it's very high, but yes, it is a highly occurring tumor. Now most affected site is your parotid, and internally is palate. Okay, in palate it is 55% of all. Okay, then you have clinical features, which is it is slightly female predilected. Okay, as we read before that. See, now the difference is in mucoepidermoid it is female predilected, and in Warthins it is male predilected, and in PA it is female predilected. So you see the major tumors are usually female predilected, right? So we can say that the gender predilection is 40 to 60 years here, and in Warthins it is also 60 to 70, and I think mucoepidermoid is also so if you see here, Mucoepidermoid usually is occurring in the younger, I wouldn't say very young individual, middle age group, right? So unlike your Warthins is occurring in older age group. PA is also occurring in almost similar age group, 40 to 60. This is 30 to 50, which is a bit more prior to 40s. Right now, most common malignant tumors seen in children. See, I told you, right? It is occurring in little young people. So the risk factor is ionizing radiation. So everybody says that, right? For a cancer, the most predisposing factor is your radiation. Now, it appears as a asymptomatic swelling at the beginning. Then the pain is a feature for high grade tumors. So if it is spreading or metastasizing and it is a high grade tumor, then it is painful, and your facial nerve involvement is usually seen in the high grade tumor. Now the differential diagnosis for this is mucocele, because it usually gives a blue to red appearance, the swelling that initially occurs. That is why people can mistake it for mucocele. Now coming to the clinical features, based on the grade of the tumor, it is classified into 3 grades, that is low grade, high grade and intermediate grade. So in low grade, it is a slowly enlarging painless mass. Okay, so it is a slowly enlarging painless mass which is less than 5 centimeter, right? It is a slowly enlarging painless mass which is less than 5 centimeter, and it is encapsulated. Cyst is filled with mucoid material. At this point, it occurs on the buccal mucosa, tongue, retromolar pad and mimics mucocele. So if you're taking a DD of mucocele, it has to be at a low grade mucoepidermoid. Then there is intermediate grade, which is same as low grade. Then eventually the clinical features of the high grade is growth is rapid, metastasized to regional lymph nodes, distance metastasis to lungs, bone, brain, subcutaneous tissue. Parotid tumors is facial nerve paralysis, trismus, damage to the ear, drainage from the ear, dysphagia, numbness, ulcerations are all features of your high grade. So low grade it basically enlarges up to 5 centimeters and it does not cause any pain. It is painless and it is not encapsulated, and it usually occurs in the buccal mucosa. It occurs in the retromolar area, tongue, and your and it mimics your mucocele. And intermediate is also the same, and high grade it is rapid, it is metastasizing to the nearby organs, lungs, bone, subcutaneous tissue. It causes trismus, it has a drainage to the ear, and it causes pain, and it causes numbness, facial nerve paralysis. Okay, and ulcerations is also a symptom. Now coming to the histopath is, it is composed of a mixture of cells. See, in the beginning we talked about a few cells, that is your mucus cells, clear cells, epidermoid cells and columnar cells. So it is mainly composed of these 3 cells. So the mucus producing cells and the epidermoid cells are the prominent cells, and the mucus cells vary in shape. Mucus cells, now we will talk about how the mucus cells are. The mucus cells are having a foamy cytoplasm, and that they stain positively for mucin. Okay, so they have a foamy cytoplasm and they stain positively for mucin. Epidermoid cells have squamoid features. So epidermoid cells resemble the squamous cells. They are polygonal in shape with intercellular bridges, and rarely they show keratinization. Okay, so we talked about mucus cells and epidermoid cells. Mucus cells have a foamy cytoplasm and they vary in shape. Okay, and your epidermoid cells, they are resembling your squamoid cells and they have polygonal shape, they show keratinization, and intercellular bridges. Now coming to the intermediate cells are also known as the progenitor cells for both mucous and epidermoid cells. These are small, basaloid, slightly large ovoid. So these intermediate cells are a type of columnar cells that we spoke about. These cells are progenitor for both mucous and epidermoid cells. They could be small, round, oval, basaloid. Okay, and their their cytoplasm is scant, pale, eosinophilic. Okay, and they are slightly ovoid. They could be large. Some tumors show variable numbers of clear cells and mucin and glycogen free. So clear cells are mucin free, glycogen free. Intermediate cells are progenitor for mucous and epidermoid cells. They are basaloid, they are large, they are oval, and they have scanty cytoplasm and pale cytoplasm, and lymphoid infiltration is usually seen. Okay, the lesion can be mistaken for a metastasizing tumor within a lymph node as well. Now classification. There is a classification of the tumors based on the histological type. Okay, the first is the amount of cyst formation. It is classified on the basis of amount of cyst formation, degree of cytological atypia, and relative number of mucous, epidermoid, and intermediate cells. Okay, so they have a relative number of mucous cells and epidermoid cells and intermediate cells. So first is on the basis of number of cells, on the basis of cyst formation, and the degree of cytological atypia. The tumor is classified as low grade, intermediate, and high grade. So in low grade you have more of mucous cells, you have prominent cyst formation, you have a high cellular atypia, and well formed glandular structures and mucin filled cystic spaces. In between low grade and high grade is your intermediate grade. You have cystic formation but less prominent compared to the low grade ones. You have your intermediate cells which are predominant because it is an intermediate phase, and you have your cellular atypia. You do not have your cellular atypia. And so we grade the low grade is to 0 to 4, high intermediate grade is between 5 to 6, and high grade is solid islands of squamous and intermediate cells are present. In high grade, solid islands of squamous cells and intermediate cells are present, which can be demonstrated and considered pleomorphic, and mitotic activity is high. So here you see high mitotic activity, and you see squamoid features are more. Then you see more of your intermediate cells, and you can demonstrate pleomorphism. Okay, and then you see infrequent mucous cells. Now the DD for this could be squamous cell carcinoma. They proliferate in nests and cords. Okay, less than to almost no cyst component. Necrosis and perineural invasion is seen. This is very important. Now what is the treatment? Treatment depends upon the location, grade, and clinical staging. Okay, if the location is parotid, then parotidectomy is done, and conservative excision is done of the facial nerve is preserved. If submandibular gland is involved, removal of the entire gland is done. Radical neck dissection if neck is involved. Low grade, good prognosis. High grade, 5-year survival chance. Okay, then coming to the variants. So mucoepidermoid has two major variants, that is sclerosing and intraosseous. Intraosseous is something which originates within the jaws. So intraosseous is kind of in the bone. Okay, it is within the jaw bones, which forms due to malignant transformation of epithelial lining of odontogenic cyst. So the cyst lining turns malignant. Okay, so that causes intraosseous MEC, which is asymptomatic, radiolucent, low grade, and affects mandible most of the times. Then there is another variant which is the sclerosing variant, which is extremely rare. Intense central sclerosing is seen that occupies entirety of the otherwise typical tumor. Okay, so in sclerosing is usually rare. Central sclerosing is seen in this type of tumor. Inflammatory infiltration of plasma cells, eosinophils and lymphocytes is seen. Complication is it is difficult to diagnose. Tumor infractions, extravasation of mucin and reactive fibrosis. So sclerosing is basically central sclerosing occurs, and in the central sclerosing is followed with your plasma cells, infiltrations of inflammatory cells, eosinophils, lymphocytes. Complication is usually it is difficult to diagnose. Tumor infracts are present and extravasation of mucin is seen. Then it is reactive. Extravasation of mucin causes reactive fibrosis, right? So that is about MEC, Mucoepidermoid Carcinoma, and it has been asked for a 10 marks lot of times. So this is the diagram. Please comment down below as to which stage you see this. This is your, if you guessed it right, it is your intermediate. Cells are seen, so it is your intermediate stage. Okay, so cystic spaces, mucus cells, epidermoid cells, clear cells, cystic spaces and connective tissue stroma is seen. Okay, now that's about your mucoepidermoid carcinoma. Then we have another important tumor, that is your adenoid cystic carcinoma. Okay, this is also very important, has been asked a lot of times, and we will finish this as well. So adenoid cystic carcinoma, 10 marks. Adenoid cystic carcinoma is a type of malignant tumor. It is also called as cylindroma, basaloid mixed tumor, pseudo adenomatous basal cell carcinoma. We'll mostly call it adenoid cystic carcinoma or cylindroma only. Okay, then definition, it is a slow growing, aggressive is the main key word which you do not have to forget while writing adenoid cystic carcinoma. So it is a slow growing aggressive neoplasm with a remarkable capacity of recurrence. So it has high recurrence. Okay, this reminds me of a cyst. Can you tell me in the comments which cyst is very aggressive and recurrent? So it is recurrence, high recurrence and highly aggressive. Right, now it is characterized by proliferation of ductal cells and myoepithelial cells. Similar to your PA, the ductal cells and the myoepithelial cells proliferate to form 4 different patterns, that is your cribriform, tubular, solid and cystic. Okay, cribriform, tubular, solid and cystic, right? Cribriform, tubular, solid and cystic are the 4 major types of adenoid cystic carcinoma. Okay, so it is firstly slow growing, painless, then it is a remarkable capacity of recurrence, and it is highly aggressive, and last but not the least, it has a proliferation of ductal and myoepithelial cells. These cells arrange themselves in 4 different patterns, that is your tubular, cribriform, solid and cystic, right? So one of the most common and the best recognized salivary gland malignancy, 5th most common malignancies of salivary gland, and the pathogenesis is it could be genetic, could be, okay, and overexpression of genes leading to oncogenesis. So genetic, in that there could be an overexpression of a gene which is leading to this oncogenesis. Coming to its clinical features, it is the most commonly involved salivary gland tumor, and most commonly involved glands are your parotid, submaxillary, accessory and palatal and tongue. Okay, so the most commonly involved glands are your parotid, submaxillary, and accessory glands in the palate and tongue. So 50 to 60% usually develops in minor salivary glands. So it usually develops in minor salivary glands as well, and majorly it occurs in your parotid and submaxillary glands, and minorly it could occur in your palate. Right now, in the tongue also it could occur. It is commonly like before ones were 30 to 40, 40 to 60, 60 to 70. This is 50 to 60. Okay, fifth to sixth decade, that is 50 to 60 years of life. That is the third decade of life. Okay, it is fifth to sixth decade of life. Then it is female predilected. Okay, that is pain is low grade, dull, gradually, which increases in intensity. So obviously it is a malignant kind of a cancer, so carcinoma, so it is not going to be causing pain uh, initially, but it is a slow growing carcinoma, so it is going to have gradual pain which is low grade and which then increases in intensity. It is female predilected. It is seen in 50 to 60 years. It is female predilected. It involves the facial nerve if it is in parotid, and if it is in the palate it is smooth or ulcerated. Local invasions is seen. Tumor in the palate or the maxillary sinus shows bone destruction, right? Okay, then perineural invasion is seen. Clinically it resembles P. This is very important, right? That it, because it is the same luminal and abluminal cells, that's why it resembles your P. Okay, now histopathologically it is composed of myoepithelial and ductal cells which arrange themselves in cribriform, tubular, solid pattern, right? Cystic is also seen, but cyst spaces are formed in of these three, so we do not categorize it separately as a cystic uh, pattern, right? So usually a combination of these is seen, but it is classified on the basis of predominant pattern. So cribriform is classical and best, okay, best recognized, characterized by islands of basaloid epithelial cells that contain multiple cylindrical cyst-like spaces. So the cribriform is a classical and a best recognized. It is characterized by islands of basaloid epithelial cells. Okay, then multiple cylindrical cyst-like spaces is seen. So this is a, you will tell me which this is after I finish, okay, in the comments. So it is a classical and best recognized. It is characterized by islands of basaloid epithelial cells that contain multiple cyst-like spaces. It resembles Swiss cheese or honeycomb pattern. Swiss cheese or honeycomb pattern, okay, and these spaces are often basophilic. Mucoid material is hyalinized. It has mucoid material. It is hyalinized. Eosinophilic product is seen. It is pass positive. Mucopolysaccharide solution is seen. Hyalinized material. It is it is having mucoid matrix, basophilic, hyalinized, eosinophilic, and pass positive mucopolysaccharide solution, and hyalinized material surrounds these cribriform islands. The tumors are found embedded in the stroma. Tumor cells are small, cuboidal, basophilic nuclei, little cytoplasm, uniform, and recurrence is 50%, and it has a mitotic activity. So this is all given like a roughly randomly, so I'm just going to give you in points how to remember it. So first is it is classic and best recognized. Second is you have your islands of basaloid cells that have cylindrical cyst like spaces. Third is it gives the appearance of honeycomb or a Swiss cheese pattern, which is very important. Okay, and fourth, it is basophilic, its mucoid material is present and it is hyalinized. Fifth is it is pass positive, and sixth is it surrounds the Cribriform islands, and the tumor is found embedded in the stroma. It gives an appearance of that. Then seventh is the tumor cells are small, basophilic, with the nuclei present, with the cytoplasm, with a little cytoplasm, and uniform. And eighth point is it is recurrence is 50%, and ninth point is it has a rare mitotic activity. Coming to the tubular type, tubular structure, point number one is tubular structures are lined by cuboidal epithelium. Then second point is multiple small duct-like tubules within the hyalinized stroma. Fourth is the lumen is lined by one to several layers of cells. Fifth is the recurrence is 80%. Solid is a group of cells with no tendency. So in solid, the first point itself says that it does not have any cyst formation, and second is it is arranged in sheets of tumor cells. Cellular pleomorphism is seen, mitotic activity is seen, focal necrosis, perineural invasion. Here the arrangement is whirling arrangement around the nerve bundles. Okay, this is the least common. Recurrence is 100%, and there is a CD4 3 test done to diagnose it. Okay, now coming to the treatment. The treatment for this is, since there is a local recurrence and distance metastasis, so the recurrence is very high, and surgical excision is the treatment, but it cannot remove the malignant transformations. And adjunct therapy is radiation therapy, and it is prone to recurrence and metastasis. Survival rate is 5 years. Solid has the worst prognosis. Solid has the worst prognosis. Palatal and maxillary sinus tumors may invade the brain, base of the brain, usually. Okay, so solid has worst prognosis. Survival rate is 5 years even after recurrence and metastasis. And palatal and maxillary sinus can be involved, which lead to the infection transfer to the brain. 35% of metastasis is to the bone and lungs. Factors influencing prognosis is site of occurrence. If it is in a very sessile site, it will recur again. And histological pattern, if it is solid, it will definitely recur and cause a metastasis, right? So that is about adenoid cystic carcinoma. Here I finished the three other important tumors other than pleomorphic adenoma. So that is all for salivary gland tumors. I hope you enjoyed, liked, and learned something. If you do not, please comment below. Thank you for watching. Subscribe for more. Bye bye.